Well, good afternoon, and thank you very much for the invitation to talk today and participate in this wonderful symposium. Just to give some background, first of all, despite what it says on my badge, I'm not a medic. I'm a physicist, and I worked for 25 years in Cardiff University, evaluating anaesthetic equipment for various government-funded projects. And some of that evaluation included looking at HMEs and filters. I carried out a Ph.D. on breathing system filters in 2004, and I've been involved for about the same length of time, 25 years, in developing British, European and international standards on various anaesthetic equipment. Currently, I'm a part-time consultant on medical devices to CEN, which is the European Standards Committee, and I've just had the honorary title of the Difficult Airway Society Professor 2015, which I consider a great honour and also a bit of a surprise as a physicist. So, conflicts of interest. While I was working in Cardiff University, I did carry out commercial testing of many medical devices, including HMEs, for various different companies. 2 articles on HMEs and filters that were published in Anesthesia in 2011 was supported by Covidian. I've received some costs for registration, travel and accommodation for various meetings, and I am working occasionally with some medical device manufacturers on various projects, but I have no particular affiliation. So just by way of introduction again, this was the title I was given. Do HME filters during low flow anaesthesia make sense? I think actually that's a wonderful title, perhaps why I was given it. But what I'd like to do then is to throw that out to you. Now, I know the topic of this meeting, so how many of you use low flow anaesthesia routinely? Where I'm defining low flow as less than 1 litre a minute. Okay, quite a number of you, of course. So how many of you use HME filters between the patient and the breathing system routinely in your anaesthetic practice? Okay. So we're starting from a point where we're using HMEs and we're using low flow anaesthesia. Is this really making sense? But we'll hopefully see. So how many of you are using HME filters primarily for humidification? Okay. That's the HME bit gone then. For filtration? A few hands, okay. For keeping the patient warm? Okay, there's a few. And you will just use them because that's what's expected. Okay. There are a few guidelines published out there. So going back 50 years or so, and the anaesthetic techniques of the time where high flows were being used and hyperventilation of patients. And Burton in particular had noticed that the effects on the respiratory mucosa was excess mucus production and diminished ciliary activity. And he stated that this could be mitigated by humidifying the gases delivered to patients. But of course this then raises the question of how much humidity do you need? Well, the assumptions for this talk is that we're talking about intubated patients, but just for a short duration, maximum of a few hours. And we're talking about using a circle system. And just some definitions first as well before we start. We've got a graph here of absolute humidity on the left against temperature along the x-axis, where absolute humidity is the mass of water in a volume of gas. A humidity at saturation is the maximum possible mass of water in a volume of gas at a given temperature. And that's the upper curve there. And the relative humidity is the actual humidity present in gas as a percentage of humidity at saturation at a given temperature. So obviously we have 100% relative humidity being the humidity at saturation, but of course we can have lower values than that. I use that now, yes. So we can have 60% relative humidity here, 30% relative humidity here. What's important is that if you wanted to get, say, 30 milligrams per litre, you would need a gas temperature of at least 30 degrees. If you're at room temperature, the maximum you can get is around 20. If you start at 60% RH and you cool that, the absolute humidity stays the same until you reach this point here, which condensation starts to occur. So the relative humidity is increasing even though the absolute humidity is staying the same. So when Jack Chalon looked at this, the levels of humidity that delivered to patients and what the effect of those was, he split 18 patients into six patients into three different groups and looked at what happens when you intubate those patients for more than 3 hours. The first group just got dry gases at room temperature. The second group got 60% relative humidity at room temperature, equivalent to around 12-15 milligrams per litre. And the third group got conditions of BTPS, so 100% relative humidity at 37 degrees. And what the group did was to score samples of ciliated cell damage by taking tracheal bronchial washings. And these are the cellular scores that they found in the three groups. So we've got cellular scores on the y-axis against duration along the x-axis. So we've got time up to 1, 2, 3 hours. And the upper line is the 100% relative humidity at 37 degrees. The orange line is 60% relative humidity at 22 to 26 degrees, so room temperature. But you can see for the dry gases, there's a significant decrease in the cellular scores at 2 and 3 hours. So Kleeman in 1994 developed this a bit further, looked first of all at the humidity that could be delivered by different breathing systems with fresh gas flows of 0.6, 1.5, 3 and 6 litres a minute, and found that only 0.6 litres a minute provided humidity more than 20 milligrams per litre. And why this was important was that another part of that same study was that he intubated pigs and delivered two different levels of humidity and compared the results from those two different groups to a control group where the two groups were ventilated for up to 10 hours. So one group got 6 litres a minute, high fresh gas flow with low humidity, and the other group got a low fresh gas flow with high humidity. The outcome measures were mucus droplet characteristics and the cilia characteristics. And what he found was that in the high flow, low humidity group, there was damage to both mucus and cilia. And in the other group, which was low flow, high humidity, there was no change or damage to the mucus or cilia, and therefore proposed from this study that sufficient moisture should be at least 20 milligrams per litre. So based on our assumptions of an intubated patient, short duration, maximum of a few hours, we're proposing that the minimum is 20 milligrams per litre. But please note, if you're going for a longer duration of intubation and ventilation, perhaps in the intensive care unit, you're going to need a high level of humidity, perhaps up to 30 or even higher. But of course, that's a different topic. So how are we going to deliver that level of humidity? Well, we've got our circle breathing system. So we've got the reaction of the carbon dioxide with the soda lime. We've got the patient's exhaled breath, which is entering the expiratory limb of the breathing system, being routed round back into the inspiratory limb. And if we're placing an HME filter between the patient and the breathing system, that's going to capture some of the exhaled moisture and return it in the next breath. How much of that all works depends on the fresh gas flow, the dry gas that's entering the breathing system, and it depends on the arrangement of the different components of the breathing system too. So here's a typical breathing system, circle breathing system, with one-way valves directing the flow of gas around the circle. We have the fresh gas flow coming in here along the inspiratory limb delivered to the patient. Patient then breathing out into the expiratory limb where we have a spill valve here, bag or ventilator connected at this point here. Gas is routed round through the absorber. The CO2 is removed, which produces moisture and heat, which is then delivered back into the inspiratory limb, diluted with the fresh gas flow. And we might or might not be putting an HME filter at this point here. So how much humidity is provided just by the basic circle system? Well, this was a study that was carried out in 1989, looking at humidity in different breathing systems, one of which included a circle system with a small absorber canister. Using fresh gas flows of 0.5, 2 and 5 litres a minute, and the same ventilation delivered in two different ways. So either with a tidal volume of 0.7 or 0.35 litres, at the frequency of either 10 or 20 a minute. This was the absolute humidity that was found. So we have absolute humidity on the y-axis and the different test conditions along the x-axis. The line of 20 milligrams per litre, which is our target that we're looking for, was obtained with fresh gas flows of 0.5 and 2 litres a minute in both cases with both ventilations, but was not achieved when a higher fresh gas flow of 5 was used. In fact, the absolute humidity was much less. Now what happens if you add an HME to the circle system? Well, this was a study that was carried out by Henriksen in 1997, looking at patients this time, 10 patients in 6 different groups, where 3 of the groups had an HME, the other 3 groups did not have an HME, and fresh gas flows of 1, 2 and 5 litres a minute were used. And their target, again, was to have an adequate humidity of 20 milligrams per litre. This was the result from that study, where on the right-hand side we have the absolute humidity delivered without an HME over a time period of up to an hour, with the 3 fresh gas flows of 1, 2 and 5 litres a minute. And you can see with 1 and 2 litres a minute, the absolute humidity is above 20, and at 5 litres a minute is just below. When an HME is added, the moisture output, the moisture in the inspiratory air is increased up to around 30 milligrams per litre and is not dependent on the fresh gas flows that are used. So HMEs do increase the level of humidity delivered to patients. And while we're talking about this level of humidity and temperature being delivered to the patient, Johansson then went on further from that and did a study with 90 patients, again 6 groups, 15 patients in each group. Again, 3 of the 6 had an HME, 3 of the 6 did not have an HME, used fresh gas flows of 1, 3 or 6 litres a minute, and looked at the humidity delivered to those patients again. And this was to see whether there was an effect of humidity and temperature on body temperature of the patient. And despite having quite a variation in the humidity levels here, so with the HME it was up to 32, nearly 33 as a maximum, without an HME and with a high fresh gas flow only down to 13 milligrams per litre, there was no significant effect of humidity on body temperature. So do we need to worry about humidity? Well, I think I could suggest perhaps from these studies and others that have been carried out, humidity is likely to be sufficient if it is at least 20 milligrams per litre. It's for short duration anaesthetic use. So perhaps we don't need to worry about the HME part of HME filters for low flow anaesthesia. Filtration, though, is perhaps another matter. So I'm going to ask some questions again. How many of you changed the breathing system after each patient? Each patient, okay. How many of you after each list?
List meaning each day?
Morning or afternoon session, perhaps. Or each day? And each week? Okay, some each week or so. Okay, thank you very much. Interesting. Well, a lot of this started because in the 1950s, perhaps even earlier, they were finding that there were cases of cross-infection occurring with the use of anaesthetic equipment, which wasn't being cleaned between uses. And when Joseph looked into this in 1952, he found huge numbers of bacteria present in the tubing and the rebreathing bag. He also noted in passing that the soda lime tower did not reduce the bacterial count. And perhaps of interest, perhaps showing how far ago this was now, that merely rinsing with water was not a sufficient way of decontaminating the equipment. When filters were first starting to be used in breathing systems, they were placed in several different places. So you might get a filter on the fresh gas flow inlet, on the spill valve, or between the breathing system and the absorber. But it was Jack Challen in 1984 who I think first suggested using a filter at this position here between the patient and the breathing system. So this provided not only filtration of the gases, but also humidification as well. And what this then does is separate single patient use equipment, including the filter to the left up to the patient, and equipment that can be reused for multiple times for other patients on the right hand side. And there's been several recommendations published about this. One is from the Association of Anaesthetists in Great Britain and Ireland, and I think their most recent one is from 2008, saying that an effective new bacterial viral breathing circuit filter should be used for every patient. An anaesthetic department should consider changing anaesthetic circuits on a daily basis in line with daily cleaning protocols. What this raises, though, is the question of what is an effective filter, and they don't really go into that. The German Society of Hospital Hygiene and German Society for Anesthesiology and Intensive Care have also put out some recommendations and guidance as well, saying that the filter should be changed after each patient. The anaesthetic breathing system can be used for a period of up to 7 days in this particular case, provided that the filter that's used has a retention efficiency for airborne particles of better than 99%. But also that the retention performance of the filter for liquids is recommended to be pressures of at least 60 hectopascals or 60 centimetres of water. So there's two different aspects here when we're talking about microbial transmission. There's the gas-borne route, which we're going to consider next, and the liquid-borne route, which we're going to consider a bit later. So for the gas-borne route, we already know from studies like this that if you nebulise bacteria, viruses, microbes into the expiratory limb of the breathing system, you can recover those same microbes in the inspiratory limb unless the gas flow is turned off for more than 1 hour. And in this particular study, they also noted again that soda lime was not bactericidal. Now, if you do add a filter between the patient and the breathing system, does that actually reduce the level of contamination? Well, this was a study that was carried out in 1997, 150 patients in 3 different groups. First group did not have an HME-F in at all, and in groups 2 and 3, 2 different filters were used. So you had 50 without an HME and 100 patients with an HME-F. And what they found in the first group, without the filter in place, that 76% of the patients had a positive tracheal aspirate, and they also found that out of those 38 patients, the breathing system also had contamination in 5 cases, so 13%. But if filters were used, again, the tracheal aspirates were positive in around 67 to 82% of the patients, but they were not able to recover any microbes in the breathing system in those cases. And in another study on this, looking at contamination on both the patient and machine sides of the filters, in this particular study they took 2001 different filters that are being used in anaesthesia, and they tried to detect the level of contamination on both sides. So there was no growth on 92% of those filters. There was growth on 5% of the patient side, but interestingly 3% on the machine side. And on some filters, it was a tiny percentage, there was growth on both sides of the filters, and the same bacteria was present on just 2 out of those 2001 filters that were tested. So it sort of suggests that contamination can pass through some filters, but at a very low rate. So how are we going to test these filters to see how good they actually are? Well, this was one study that was carried out using a surrogate for Mycobacterium tuberculosis on a pleated mechanical filter. And they nebulized this microbe into the breathing system and were not able to detect any downstream, giving a filtration efficiency of 99.99% to 99.999%. Well, that's okay, but what about other types of filter that are available? Now this is a scanning electron micrograph of the surface of that particular filter. So we have the scale here, which is about 100 microns. And if you remember, bacteria are roughly a couple of microns in size. So despite this being a very dense filter in this particular filter material, it's still an order of magnitude here larger than the microbes that it's trying to prevent. And obviously this is important because you want the gas to flow through without too much resistance. But if we compare that to electrostatic filters that are on the market, so this is at the same scale, and there are two types of electrostatic filter on the market, fibrillated and turbocharged. So these are on the same scale, and you can see the difference in the filter, fibres of the filter in their size, their diameter, and the spaces between them. So when we carried out a study on this was published in 2000, we challenged different filters available on the market at that time with a bacterial challenge, which was Bacillus subtilis, and a viral challenge, which we used MS2 for. We looked at 12 different filters. 5 of those were pleated filters, and 7 were electrostatic. 2 of them were the turbocharged, and 5 were fibrillated. And these are the results from the bacterial challenge from that study. So on the left-hand side, we've got filtration efficiency on a sort of log scale. So we've got 99%, 99.9%, 99.99%, and so on. And along the x-axis, we've got the different filters arranged into groups. If you look at it the other way, if you come down the y-axis scale, between these different intervals here, we've got 10 times more microbes getting through. So 99.99% to 99.9%, 10 times more microbes getting through. Another 10 times more if we go down here. So for our pleated filters, they were all very, very efficient, 99.9999%. Really at the limit of what we can detect. The electrostatic filters were around 99.9%, so orders of magnitude different, with the turbocharged filters somewhere in between. For the viral challenge, on the same scale, you can see that the filtration efficiencies are now a bit less. Everything has moved down a little bit, so the pleated filters are generally around 99.999%, still very effective. The electrostatic filters are around 99%, with the turbocharged filters somewhere in between. But of course, we're interested in so many different bacteria and viruses, things that we want these filters to stop going through into the breathing system and then back from the breathing system back into the patient. And the problem here is that the filtration efficiency for particles of different size varies. So when we were developing the international standard for filters, what we did was chose an industry-based standard for this, where you challenge the filters for sodium chloride particles, which are known to be the most penetrating for filter material. And this is around 0.3 microns. And what this does is give you then the worst case efficiency for filters. So following publication of that standard, we then carried out a study for the Medicines and Healthcare Products Regulatory Agency in 2004. And by now, there were 104 different filters available on the UK market, split into electrostatic and pleated, and also split between those intended for adult and paediatric use. And why that's important is, sorry, come on to that in just a moment. The performance, we measured filtration performance based on the standard, but we also looked at the resistance to gas flow of these devices and their internal volume. So, and the reason why we wanted to split them into adult and paediatric filters was that from work that I'd carried out around that time as well, we knew that the filtration performance also depends on the flow of gas that's used to challenge the filters. So we chose 30 litres a minute for adult filters and 15 litres a minute for paediatric filters. And when we were looking at the resistance to gas flow, what we actually measured was the pressure drop across the filters, again at those two different flows that we'd chosen for the filtration performance. Now these are the results from that study on all 104 different breathing system filters available at the time. On the y-axis we have filtration efficiency, and this, remember, is now looking at sodium chloride particles of the most penetrating particle size. On the x-axis we've got pressure drop in pascals, so 100 pascals is around 1 centimetre of water. The blue dots are for pleated filters, the orange ones are for electrostatic, and the lighter colours are those that are intended for paediatric use. The size of the dots are in relation to their internal volume. So in an ideal world, what we'd like is a small filter with a high filtration efficiency and a low pressure drop. From the German recommendations, what they were suggesting was that you should only use filters which are above 99% efficient, tested this way. All the pleated filters that we tested were above that level. Some of the electrostatic filters were, but not all. Just like to draw your attention to that group of 5 filters there, which have a very good filtration efficiency, have low pressure drop, which is what we want, but they're large devices. They're adding a lot of dead space to the breathing system. In contrast, if we look at these filters here, we have 2 small filters suitable for paediatric use, but they have a high pressure drop. And remember, this has been tested at a lower flow anyway, so a higher pressure drop and with a lower filtration efficiency. I mentioned there were 2 routes of microbial transmission, the gas-borne and liquid-borne route. For the liquid-borne route, what we're really concerned about here is if you get condensation in the breathing system, which you're likely to get in a circle breathing system with low flow, if that condensation gets contaminated from somewhere, that condensation then enters the filter. The condensation covers the surface of the filter. When the ventilator then attempts to deliver the next breath, the pressure is then going to rise within the breathing system until either the liquid is forced through or a pressure relief valve or alarm activates. So going back to our circle breathing system here, well, this is particularly important if the filter is not vertical, as in position here, but is actually more horizontal, where you can get condensation getting into the filter and covering the surface of the filter. So this was a study that my colleague Claire Cann carried out in 2006, and it was looking to see what pressure was required to force liquid through different filters, again available on the market. So the pressure was gradually increased until we observed liquid breaking through. And these are the results from that study. So we've got the pressure that breakthrough occurred on the y-axis against the filters on the x-axis, again grouped into pleated and electrostatic filters. And if I put the line on from the German recommendations, which was 60 centimetres of water, 60 hectopascals, you can see the electrostatic filters were all much lower than this, and 3 of the 5 pleated filters were above that, with 2 not really complying with that requirement. We were just using water, so then the question is, well, what happens if there are microbes in that liquid? Do they pass through the filter as well? Well, this was a study that David Scott carried out in 2010, and he demonstrated that if liquid does indeed pass through filters, then any microbes in that liquid passes through as well. And again, he found that pleated filters required higher pressures than electrostatic. While we're talking about the use of HME, some filters, just drawing to a close now, I should say that they're not without their problems. And I published a review of this in 2011, trying to bring together problems that had been reported on their use, and I know others have done this as well. So in particular, they add resistance to gas flow, within the breathing system. This can cause delays with induction of anaesthesia, and of course it can also cause problems for patients who are breathing spontaneously if you're adding a lot of resistance. If you get a lot of condensation or other liquid, previous speaker mentioned about secretions as well, if those enter the filter they can block and prevent ventilation. And by adding dead space you might get hypercapnia occurring, particularly if lung protective low tidal volumes are used. And adding dead space can also cause problems with CO2 monitoring, particularly in paediatrics. This has been reported in a number of studies. So in summary, I would suggest that 20 milligrams per litre is adequate humidity for short duration anaesthesia, and that level of humidity can be provided with a circle breathing system when using a low fresh gas flow. If you do use an HME filter, it will increase the level of humidity delivered to the patient. For the filtration side of things, if any part of the breathing system is reused, a filter should be placed between the patient and the breathing system. And that's from guidance from professional bodies as well. Microbial transmission can occur from both the gas and liquid-borne routes, and for both those routes, mechanical filters seem to be more effective than electrostatic. So, do HME filters during low-flow anaesthesia make sense? Well, I would suggest that perhaps the HME part, no, not really necessary. But the filter part, yes, if the breathing system is reused. But please do remember, not all filters are the same, and you need to balance up the filtration efficiency, the resistance to gas flow that they put into the breathing system, and their internal volume. And there have been reported problems with the use of filters. Thank you very much. Any reflections?